The second case is of a 66-year-old gentleman who presented with inguinal and axillary lymphadenopathy. Initial biopsy of the lymph node showed grade 2 follicular lymphoma, and further staging studies with CT scan showed widespread disease with bulky disease up to almost 10 centimeters, as well as pleural effusion. Bone marrow showed 70% involvement, and patient also had anemia and elevated LDH. We don't have any additional data on the PET scan regarding this patient, but he was treated with R-CHOP, responded, achieved a complete remission, but unfortunately relapsed after 19 months. At the time of relapse, the patient was then again treated with bendamustine and rituximab, this time only achieving a partial response that lasted 6 months. 6 months after completing the bendamustine and rituximab, the patient presented to clinic with complaints of fatigue and abdominal fullness. CT scan showed again progressive lymphadenopathy, particularly in the abdomen and pelvis, and he was started on idelalisib. In contrast to our first case, this is a much tougher situation. This is a gentleman who had a short initial remission duration, less than 2 years, now has had an even shorter remission duration after only achieving a partial response to second-line chemoimmunotherapy. We know from recent data from the Lymphocare study from Carla Casulo and others, looking at the impact of early relapse. The FLIPI score alone is not very accurate at predicting outcomes. However, we do know from this study that patients who have a relapse within 24 months of their diagnosis have a very poor outcome. Fortunately, this is only about 1/5 of patients, but patients in this category really only have about a 50% 5-year survival. So this further stratification by time to initial relapse really helps guide us in terms of our therapy. For 80% of the patients, fortunately, they'll do well. There'll be a later relapse, if at all. And those patients, the key is to use restraint to try to minimize toxicity, at least in my perspective, and not be overly aggressive. However, in the 1 in 5 patients like this unfortunate gentleman who has had an early relapse, we need to think about novel strategies. This is where I really talk about clinical trial options because the outcomes are much poorer. The prognosis of this patient at diagnosis is really only defined by the FLIPI score in terms of a formal definition. This patient actually has the same risk category as the first patient. However, this patient has every FLIPI point, but still would be categorized as high risk, which really shows the limitations of the FLIPI score. You can be high risk and have likely a better prognosis and still be called high risk and have a poor prognosis like this patient. So we do need better prognostic markers clearly than the standard FLIPI. The M7 FLIPI may be helpful, but really not ready for prime time at this point.